Good afternoon. I am Steve Posnack. I'm the Executive Director of our Office of Technology at ONC, and live from ONC Studios. You are joining me here to talk about the API conditions of certification and more. Thank you for joining today's webinar. This webinar is part of a running series that we're doing to explain the various components of our Notice of Proposed Rulemaking. The next rulemaking webinar that we'll be covering will dive deep into the information blocking exceptions and will be held on March 19th at 2 p.m. Eastern Time. We'll have one more webinar on the NPRM overview again, which will be held on March 28th at 2 p.m. Eastern Time as well. So if you didn't get those or don't go back to listen to the broadcast, you can visit our website at healthit.gov/NPRM, and there are a variety of fact sheets, FAQs, other types of education materials, infographics, and the information related to the forthcoming webinars. Before I dig into the content that I'm going to cover with you today, I wanted to make a few general overview points. The first is that our proposed rule is now open for public comment, and there's a formal process for you to do that. You can access the public comment docket through healthit.gov/NPRM. That was the URL I just read off to you earlier. If you choose to go through the federalregister.gov, you can type in the docket information or search on any one of those keywords that's in that longer URL. Equally, we follow what's called the Administrative Procedure Act, which is how federal agencies follow the rulemaking process. And as part of this webinar, as well as others, we are providing the content and context associated with the NPRM and its preamble, and we won't be able to interpret in any additional detail nor clarify or provide further guidance at the moment. So what's in the rule is what we're able to talk about, and appreciate any comments or other clarifications that may be requested via the chat box area, but I would encourage you again to go through the formal comment period process that again is available either through our website to get you to the Federal Register, or as well to get you to directly to the Federal Register's website for our rule. All right, we are ready to dive in. And I see we've got a number of folks that have just joined, so welcome. I'm going to give you first a high-level overview before I dive into the API conditions of certification. And the first thing to talk about is that there are two statutory sections that we've implemented together as part of the 21st Century Cures Act. And so the first section relates to what are called conditions of certification. There are 7 that are noted in the statute, the 21st Century Cures Act. I'm going to cover section 170.404 that's got APIs without special effort labeled there. And then as a corresponding sister set of proposals in our rule, we also cover what are called information blocking exceptions, and there happen to be 7 of those as well. There's a presumption under the statute that health information will be accessible, usable, and exchangeable for any types of interoperability related purposes, and I'll cover in a little bit more detail some of the broader context in which information blocking relates to the specific API conditions of certification. And that's the one highlighted there on the left side. So these two statutory sections have a lot of interplay. I hope you'll find as I go through the presentation that there are these 2 layers in which the statutory provisions intersect, as well as other law and policy that's already on the books that can intersect with the conditions of certification as well as information blocking exceptions. A quick acronym check. You know we all love acronyms in the federal government. There are a few that you may be familiar with and a few that may be new. So first being API, which is Application Programming Interface. Another one, which is FHIR, not spelled the traditional way, but FHIR, which is an HL7 standard. We have the USCDI, which is the United States Core Data for Interoperability. The ARCH, the API Resource Collection in Health, which I'll talk about a little bit more in my slides. And then the COC, which stands for Conditions of Certification. In case you see any of those in future slides abbreviated, those are your shortcut resource. So I'm going to cover the really big picture in terms of scope and applicability related to certified API proposals. And in order to first understand how our proposals around certified APIs fit within the broader statutory framework and our regulatory proposals, it's important to understand the broader universe of what's called information blocking. And according to the 21st Century Cures Act, there are 4 actors to whom information blocking related policies apply. The first being certified health IT developers, or otherwise referred to as developers of certified health IT. So those would be health IT developers that go through ONC's health IT certification program. The second actor being health information exchanges. The third being health information networks. I'm going to pause here. These 3 actors are covered under the statute by enforcement authority from the HHS Office of the Inspector General that can also bring with it penalties in a monetary form of up to $1 million per violation. So those first 3 actors are covered by the monetary penalties that can be enforced by the HHS Office of the Inspector General. The last actor is healthcare providers, which is also a covered actor according to the statute. And there are no specific identified explicit monetary penalties that would apply to healthcare providers. However, the Secretary is granted broad authority to establish what are called appropriate disincentives for healthcare providers that may engage in information blocking. The important part in these second 2 bullets related to information blocking is that it is scoped to what's called electronic health information, and there's an expectation under the law, as I mentioned earlier, that the electronic health information would be accessible, exchangeable, and usable unless a particular interference is required by law or covered with an exception. So again, the presumption under the statute is that electronic health information will flow, and that only under certain reasonable and necessary circumstances would one of these covered actors be permitted to withhold sharing that information or making it accessible or usable to other parties. And that's what the exceptions are in place for. By meeting or covered, being in a covered exception process, that would mean that the covered actor would not be subject to penalties or disincentives. The important part in these smaller boxes that are part of that information blocking universe is that information blocking as a whole, and in its relationship to electronic health information, covers a broad range of both technical components as well as business practices, policies, and the like. And so I've just included a non-exhaustive list of many of those different dynamics. They are referenced in a defined term in a regulation called interoperability elements. And so it includes interfaces of various kinds, proprietary APIs, and not just those that are certified, contracts, business practices, other types of services, licenses, and rights. And again, it's important to know that any of the covered actors that are referenced in that box to the right, insofar as they engage in practices that could invoke any one of these technical or policy or organizational behaviors, could find themselves in trouble from an information blocking perspective. Now, the API condition of certification fits within that universe. There are many other conditions of certification, as you saw on my prior slide. When it comes to the API conditions of certification, the first thing to note, in deference to or in difference to the covered actors from information blocking, the universe of actors that are covered by the API conditions of certification is that it applies only to health IT developers that seek certification to the specific API certification criteria. So we have many, if you're familiar with our certification program, certification criteria to which health IT developers can seek certification for their products. So one example here that I use to distinguish the coverage of this condition of certification is related to public health reporting. We have a few public health certification criteria that relate to, say, immunization reporting. And in the context where a health IT developer would seek to get a module, as we refer to them, certified only to that public health reporting certification criterion, it would not invoke the coverage of this condition of certification. There would be other conditions of certification that would apply to that health IT developer, but in the context of the API condition of certification, this condition would not apply to that specific health IT developer. Within the broader statutory condition of certification, which I'm going to cover in much greater detail for you later, there are 3 specific conditions that we've proposed related to transparency, permitted fees, and openness and pro-competitive practices. There are also, importantly, as referenced by the statute, maintenance of certification requirements as well. And so it's just another reminder in terms of how the statute is constructed. There are both conditions of certification, which are generally what needs to be done up front in order for a health IT product to get certified, and then subsequently maintenance of certification obligations that could be imposed on health IT developers. And again, from a context and scope perspective, it's important to remember that the conditions of certification, as laid out by the 21st Century Cures Act, provides ONC with the statutory authority to regulate the health IT developers' business practices as a whole. And so that's an important distinction to keep in mind in comparison to our original statutory authority from the HITECH Act of 2009. Within the conditions of certification for the APIs, there are specific API certification criteria that are supported by, reinforced, and get further clarity in terms of industry practice and behavior. And there is a new proposal that we've included in order to implement the overall API condition of certification that is a cures-focused criterion. It's a secure standards-based API proposal. There's a focus on read-only access to data. So typically from a text speak perspective, you can write into systems and you can read from data from systems. This criterion is focused on reading data out as opposed to any requirement at the moment to have the API engage in write access. There are specific standards that we've included to associate with the certification criterion. I'm going to cover those in more detail. And the other broader point to keep in mind as I go through the deeper dive is that the API is generally proposed to support both provider access to the APIs as well as patient access use cases altogether. Okay, so we're going to cover the API conditions of certification. The first thing that I wanted to give you an orientation about is the who we're talking about. So the first three types of actors that we have described in the proposed rule to keep sense and help everyone better understand the type of roles that are involved in API technology. The first actor is who we call an API technology supplier. And so in kind of layman's terms, that's the health IT developer of an API technology that gets presented for certification. So when you think of API technology suppliers, think of the typical electronic health record developer or other type of service provider that would be seeking certification to the API certification criteria. Then you have an actor that we refer to as the API data provider. And so in a colloquial sense, these are healthcare organizations that deploy API technology. And the kind of rationale or mnemonic for the name is they have the data. So they're the ones that are providing data via APIs. And so we choose to refer to them as API data providers. And then lastly, we have a more general term for any type of service or app or third party that would interact with the API that are made available by API data providers, including themselves. And we refer to that general category of actors as API users. And so again, these are persons or entities that use or create software applications that would interact with the API technology. So what is it that we're really talking about in terms of what's in scope from the broader condition of certification? This condition, as I mentioned earlier, would apply to all API-focused certification criteria. If you happen to speak regulatory ease, like I do, then these certification criteria references are the ones that are the specific certification criteria that are invoked by this condition of certification. But practically speaking, given our proposals, what we're talking about is regulating the standards conformance and the overall health IT developer behaviors associated with deploying what are called FHIR servers. And I'll talk a little bit more about the server dynamic in a bit. Lastly, as I mentioned earlier, the API condition of certification applies only to health IT developers and the health IT that is certified to the specific API-focused certification criteria. All right, so there's a lot to cover, but in terms of talking about the upfront issues related to APIs, which you may have heard of, you may think, oh, this is a brand new thing. Is it secure? And I wanted to cover a few key points today with you to give you a grounding in terms of the compare and contrast related to what is currently in production from a healthcare perspective today and the broader policy environment in which FHIR servers and the APIs to access them will be made available. So today in healthcare, in our healthcare ecosystem, health information is made available via web applications or made accessible to web applications over the internet via what are called web servers. And for lack of a better name or description, for the general experiences that we all have as patients today, accessing our health information via portals, be it for our kids or our parents or ourselves, there are traditionally what has been referred to in industry as a tethered portal. It's associated with a specific healthcare organization. You type in a specific web address, and the portal interacts through your web browser or other type of application with that web server. And the important point to mention here is that when it comes to third-party applications, which will be the future of the API ecosystem in healthcare, the work that they have to do programmatically from a software perspective to securely connect to what are called HTTPS-based web servers is very similar to the experience that occurs today. And the way to kind of reinforce that is to say the same information security steps used by HIPAA-covered entities for the tethered portals that they've made available in production can be and would likely be the same steps that are being used for third-party apps going forward. And I'm going to do a quick compare and contrast for you to help orient the security-related componentry. So the steps to keep in mind, they're the what, and then the compare and contrast to keep in mind is how these security steps are put in place via the particular security steps. So the first step that we have when we talk about an app-based ecosystem is that for apps, and this is under the third-party app column all the way to the far right, each app must be registered, and they get what's called a unique client ID and at times a client secret as well. And so that can uniquely identify the app as that is connecting to the HIPAA-covered entity's web server for the perspective of access to particular data. When it comes to registration for a portal, there's just a one-to-one connection, so it's not really an applicable step per se related to multiple possible third-party apps that could connect from a programmatic perspective. When it comes to the secure connection, this is one where there is a direct parallel between what we experience today and the same type of programmatic interaction for a secure connection related to third-party apps. And so our typical experience today will be to type in, portal.drxyz.com. The visual experience that we get is directly with the portal based on the server programmatic responses to our web browser and what it's displaying. When it comes to the third-party app, it's the same exact connection. You just don't see the lock in your browser like you would with the kind of tethered portal perspective. The connection happens in a more programmatic way, and the app connects directly to the FHIR server, establishes that secure connection, and the visual experience that you get would likely be through the user experience that the app has deployed. When it comes to user authentication, as many of us know from the multiple portals that we have today, we go to our healthcare provider. They either register us or give us particular information to use to create an account. And typically we create a username and password, and that's what we use when we access the portal to a particular healthcare provider's organization. When it comes to the connection that would occur via the third-party app, when it comes to authentication and the app's connection to the FHIR server, the app will get redirected to the authentication environment that the healthcare organization maintains. And so when it comes to the patient entering in their credentials, they are entering in the exact same credentials issued by their doctor's office or the web portal itself to give access to the app to access their health information. And so again, an equivalent step. It happens in a slightly different orchestration pattern, but when it comes to user authentication, the healthcare provider is getting that same identity verification that they otherwise would get via the patient portal when it comes to the app and the app process. And the other important point to mention is that the app never gets to see or access the patient credentials. As part of the OAuth 2 process, which I'll cover in a little bit more, it's a security standard approach, the app gets redirected to it gives the patient the opportunity to enter in their data or their user authentication information and credentials directly into the healthcare provider's suite of authentication information. And so again, it's a different security parameter or step, but it's important to note that if they're practicing best practices in industry and they're following the standards that we've put forward, the app wouldn't get your specific the credentials that your healthcare organization has issued. And then lastly, when it comes to app authorization, when you interact with your portal, the actions are between that. Again, it's a one-to-one connection. All the actions are trusted by the web server and your patient portal, and all of your data is accessible via that patient portal because that's your one conduit into your health information. When it comes to third-party apps and their connection, the FHIR server does not necessarily need to explicitly trust or implicitly trust the app, because there's this process that goes on where you as a patient are telling the healthcare organization, this is the app that I trust. This is the app that I want to give access to my data. And there's processes in place for you to identify the scope of data that you'd like to be made available to that particular app. And so if you'd like to make medication data only available to a particular app, most apps have processes in place to let you pick the type of data that you would make available to that app. And then subsequently, to the user authentication part, because authentication and app authorization happen in the same orchestration pattern here. After the patient goes through that last step of authentication and authorization, the app gets what's called a token, an access token, which is time limited to grant the app access to that FHIR server and to be able to get your data. And there's lots of detail here. I know those that are more technically astute will probably think that I've glossed over a very detailed topic, but I just wanted to give everybody a grounding in the what it takes to secure the APIs, the commonalities effectively between what's currently in production and the techniques that would be deployed in response to the certification requirements that we put forward. The other important point related to the broader policy overlay that we have is that there's the HHS Office for Civil Rights, and they issue a number of different frequently asked questions. They have a few related specifically to HIPAA privacy FAQs on patient access, and the numbers are up there. So if you type them in to the URL that I've provided, they will give you more access. And so the first one, when we think about patient access via a third-party application and the like, is do individuals have the right under HIPAA to have copies of their PHI transferred or transmitted to them in an unsecure way? Is the kind of the shorthand. And the short answer to this question is yes. They do have the right to have their data transmitted to them if they request it to be transmitted in an unsecure way. It's important to keep that in mind. The second FAQ that they've issued is related to the covered entity's responsibility. And so if a covered entity is a covered entity responsible if it complies with an individual's access request to receive PHI in an unsecured manner. So if I ask for my data and I say, please send it to my email account in an unencrypted way, and then the information is intercepted, is the covered entity responsible if it complies with my request? And the short answer from OCR is no. It's important to keep that in mind. And then lastly, there are concerns related to the liability of a HIPAA covered entity when they respond to an individual's access request to send that PHI to a third party. And so that third party could be a number of different types of organizations or entities, but let's keep it in the context that we're using today. It could be a third party app. And so the short answer to this question is, what is the liability of a covered entity in responding to an individual's access request to send their PHI to a third party? Short answer really quickly in summary is the covered entities may rely on the information provided in writing by the individual to have that information directed to a third party. However, covered entities must implement reasonable safeguards in otherwise carrying out that request, such as taking steps to verify the identity of the individual making that request. The last part, which I've put in quotes as a sub-bullet here, that OCR emphasizes at the end, further, the covered entity is not liable for what happens to the PHI once the designated third party receives that information as directed by the individual in the access request. So again, as you consider the proposals that ONC has put forward related to the specific technical requirements for API certification, and you keep in mind the information blocking proposals that are also applicable to healthcare providers, it's important to keep in mind the broader policy environment in which all of us operate. These FAQs and policy guidance from the Office for Civil Rights related to patient access. All right, so we're going to dive into the specific certification criteria now. I'm going to start covering a lot of content in the next 40 minutes or so. There's a lot of text on these slides. They're really more for your reference. In general, I wouldn't do as text-heavy slides if I was given a a normal presentation, but I wanted to make these slides available for your reference, and you can use them to consult, side by side with the rule as you read through the preamble of this particular section of our proposed rulemaking. So we have a number of specific technical functions, that's the required capabilities in this left column, related to APIs and the standards-based way in which we propose to establish certification criteria for API technology. The middle column here identifies the applicable standards that we've proposed to be associated with those certain functionalities. And then the additional context that we provide to the right is that for certain required capabilities in the specific certification criterion that we've proposed, there may not necessarily be, like app registration, a technical standard that we've explicitly proposed to require in order to get certified, but there is associated condition of certification or health IT developer behaviors that are associated with that capability overall. I'm not going to read through all of these in detail for you, but again, it's another quick reference of here's what we've proposed. There are a number of areas where we've sought additional comment for some of these, and I would encourage you to dig in and read many of those separate sections in order to get a full context for what your comments could be related to some of these additional proposals. All right, the one thing to mention for those of you that are health IT developers or in the FHIR server development market is that for the better part of the past 6 months, we had publicly released last fall and have continued to develop in an open community way a FHIR server testing tool that we refer to as Inferno. If you'd like to check it out, it does attribute many of the proposals that we've made now are built into that tool's testing, and we're continuing to update it over the next few months to reflect all of the detailed proposals that we've included. So if you're interested in FHIR testing, specifically for FHIR servers in conformance to FHIR Release 2, the Smart App Implementation Guide Framework, all that's there for you to test out. The other thing from a context perspective, those of you that are familiar with ONC's regulatory work will remember that in 2015, we released our 2015 edition final rule. There were API certification criteria included in that rulemaking, and they were non-standards based at that point, so they were just functionality specific. What has occurred since that time is that as hospitals and MIPS eligible clinicians participate in the various Centers for Medicare and Medicaid programs with which there are either payment incentives or other types of reimbursement methodologies, they've had to adopt certified EHR technology to the 2015 edition. That compliance requirement started this year. So 2015 edition systems, certified systems are the only ones that are permitted to be used for the specific CMS programs that reference certified EHR technology. And in large part, as we looked at the data available through our certified health IT product list, we saw, and this is a depiction of hospitals, percent of hospitals with a 2015 edition certified API. The ones that were partnered with or customers of health IT developers that have used FHIR as part of their 2015 edition certification is actually quite high and represents a majority of the hospitals out there today. And so even though it may appear that our new API certification criterion is a step in the future direction, it actually meets the industry where it's best prepared to comply with the regulatory requirements that they've already been working to meet for the past 4 years. So again, just from a context perspective, FHIR is actually widely deployed. Many of the hospitals today and a majority of eligible clinicians in the MIPS program work with health IT developers that are actively deploying, if not already deployed, FHIR-based APIs for their patient access requirements. Okay, so I'm going to transition into a little bit more of the technical related discussion. There is a proposal as part of our rulemaking to replace what's called the Common Clinical Data Set with what is now referred to as the United States Core Data for Interoperability. And a quick history lesson here, we in our past rulemakings have had a shorthand reference to a list of data, an enumerated list of data that needed to be addressed as part of a number of different certification criteria. And in order to make our lives easy and make the lives easier of our regulated community, we decided to come up with a shorthand term which we referred to as the Common Clinical Data Set. And that was embedded in our certification criteria, and we use that as, again, a quick reference to a larger set of data. within the certification requirements. We have now proposed to abstract that out, make that data part of a larger data set, slightly larger data set that we reference in the USCDI, and have proposed to adopt the USCDI as a separate standard that we would steward over time from a data policy perspective. So there are a number of what we call data classes that are the top line titles for each of these boxes. The new ones, just to call out a few distinguishing characteristics, as part of this proposed rule, we've included clinical notes as a data class, and then the subsequent 8 clinical note types that are referenced there, as well as provenance as a data class as well, and the 3 different types of provenance, kind of metadata, the author timestamp, and the author organization that would be related to the data that's actually being exchanged. And the important point to keep in mind with respect to the USCDI is that with respect to the specific data classes or data elements within, we do reference what are called the semantic standards, so the actual detailed either vocabulary, terminology, code system bindings that would be associated with them. So medications is an easy one to pick on. For medications, we reference as part of the USCDI that RX norm needs to be used as the standard way to represent medications. However, as you may know, there are a number of different what are called content exchange standards that can be used to help get data from point A to point B. And so one that we reference in our rule quite a bit is called the consolidated CDA. And so when it comes to the US core data for interoperability, this list of data here needs to be translated into a content standard that can be the structure, the syntax in which all this data can be represented and then traverse, across the wire from one point to another. And then the recipient knows, hey, I've received this consolidated CDA and the data, within according to particular specifications. When it comes to FHIR, there are what are called FHIR resources. And so it's a different way of organizing health data. It's in a bit more of a modular fashion. And as we looked at the USCDI and translating the USCDI for API usage, we recognized that we needed to translate the USCDI, which again is data policy. It's not attributed to a particular content standard. We needed to translate the USCDI into computable content. And so we looked at the applicable FHIR resources that were available, and we selected those FHIR resources that were best positioned to support USCDI data classes and data elements. And that's what gets translated into the API resource collection in health, otherwise referred to as the ARCH. So there's a lot of derivative work that already existed out in industry. If you're familiar with the Argonaut project, many of those FHIR resources were represented in the ARCH as the industry's best practice or de facto agreement that, all these patient demographics need to go in the patient resource. Go figure. And so, a lot of those industry decisions and industry feedback through the standards development process have already occurred, and we sought to just reference and leverage that work that's already been done. But there are some unique differences between the USCDI and available implementation specifications or profiles in the FHIR space, clinical notes being one of them, data provenance being another. So there isn't a particular implementation guide that references the provenance FHIR resource. And so in order for us to translate the USCDI into specific FHIR resource bindings, we needed this intermediate step that we've used to advance the translation from the USCDI to FHIR. And to give you more detail about the ARCH, you may be asking, like, what is this thing? Why did ONC come up with a new acronym? Hopefully I've covered the why behind it. And now to talk a little bit about the what. So the what, again, the ARCH is 15 specific FHIR resources aligned to support the USCDI. It references the 2015 edition new API certification criterion, starts with the patient FHIR resource in the center, and the rest of the FHIR resources that fit and associate with the USCDI for its support fold in around. Obviously, this is a visual depiction to help you remember. But again, the bottom line here is that when it comes to translating USCDI, which is content standard agnostic, into FHIR, we use the ARCH from a regulatory administrative perspective to help give that guidance to industry. It also becomes important over time as we look to make updates to different versions of standards, as part of another proposal that we include in the rule related to what we call the standards version advancement process. By referencing these FHIR resources as a separate document effectively, we would be able to, if we finalize that proposal, use the standards version advancement process to keep the FHIR resources necessary to align with the USCDI in sync. And so as we go through the standards version advancement process for the USCDI, we'd equally use any decisions to update the USCDI to then do the double check to look for alignment and symmetry with any of the FHIR resources that may need to be named in or included or updated as part of the API resource collection in health. All right. This next slide is going to be one of your takeaway slides from a bird's eye view perspective. This will cover in its totality from statute to the maintenance certification requirements what the API conditions and maintenance of certification are up to, what we require and propose to require from a certification perspective. So let's start first with the API condition of certification as it relates to the statute. The API technology supplier must publish APIs and must allow the health information from such technology to be accessed, exchanged, and used without special effort through the use of APIs or successor technology and so on and so forth. And so when it came to without special effort, we looked and understood and had many interactions with stakeholders in the field as we were preparing our proposed rule and said, what are those things that would create special effort from an industry perspective, and what we thought would constitute special effort. And we broke it down into 3 overall practices. So one practice is related to documentation and overall transparency from a health IT developer perspective. It's hard to get documentation. Access to terms and conditions, especially with proprietary APIs, would be difficult for third-party apps, other services that healthcare providers would want to interact with. And so we've proposed a specific set of transparency conditions related to public accessible documentation that cover terms and conditions, fees and their structure, as well as an app developer verification process that focuses on the app developer itself, not on the specific app applications. The second set of practices that could constitute special effort relate to permitted fees. And so there are a number of practices that we had been exposed to via our conversations with stakeholders, that pricing practices for API access, connections, overall engagement with health IT developers were quite variable, and that they were being used from those different stakeholders' perspectives to stifle innovation and to prevent new entrants' abilities to establish partnerships with healthcare providers. And so the permitted fees proposals that we have include a number of different guardrails that are in place that would allow for health IT developers, API technology suppliers in our context, to get reasonable returns on their investments, to support R&D, to support API upgrades that their customers may be requesting, but provide, again, the guardrails around the access and use exchange of API, electronic health information via those APIs. And then lastly, we heard about anti-competitive behaviors, which obviously, pricing practices is kind of one of those subsets, but a number of broader types of behaviors out there in the field related to openness and pro-competitive practices. And so we tried to address through our proposals a number of different ways in which APIs could be accessed without special effort, consistent with and juxtaposed with what we call reasonable and non-discriminatory terms. I'm going to cover these in a little bit more detail, but again, the high-level bullets are here for you as well. All right, from a maintenance of certification perspective, an API technology supplier, if they so choose to do the vetting process of the app developers, wouldn't be permitted to drag their feet when it comes to actually approving those apps to be production ready. And so we have a proposal around that associated with the app developer authenticity verification. The second maintenance of certification requirement, which again is in this case a post-certification requirement, would be that health IT developers would need to support the publication or what are called service-based URLs, but otherwise the web address, the server, the FHIR server API endpoint for all of its customers and make sure that that information is publicly available in a computable format at no charge. And so again, if we talk about healthcare providers using their own APIs, or importantly for patients to get access to their health information, those apps need to know where to point their app in the right direction and to what healthcare organization's FHIR server in specific, based on who the patient may say has their health data. Lastly, from a compliance standpoint, we have requirements that we've proposed related to the overall rollout and updates associated with this new certification criterion, the standards-based API. And so we had a choice to create arbitrary deadlines for the different stakeholders that would be related to our certification program, but instead we chose to establish a single deadline by which the API technology supplier and its customers, so a health IT developer and its various healthcare organization customers, would need to meet in order to comply with the final rule's effective date. And so it would be, once the final rule is issued, there would be 2 years after that, 24 months after the final rule's issuance and effective date, by which the API technology supplier would be on the hook to roll out this new API functionality to all of their customers. So again, recognizing the distinguishing and different architectures and approaches that health IT developers take, some that may have a more cloud-based architecture could take more time on their development and user experience testing than those that may need to actually send out teams to make upgrades on premises at a particular healthcare organization. And so recognizing that we wanted health IT developers to have flexibility to determine the approach that they were going to take to meet this deadline, that was part of the rationale behind the 24 months and just setting a single deadline for the ecosystem at large. All right, so now I'm going to cover the specific conditions of certification. I'm going to do a deep dive on the transparency conditions, permitted fees in very specific, and then summarize the pro-competitive and openness ones at the end. So when it comes to the transparency conditions, and I'm going to go through this pretty quickly, the business and technical documentation published by the API technology suppliers needs to be complete, and they need to be publicly accessible. And there's material information that needs to be provided by API technology suppliers, and I'm going to focus on the bolded text that's underlined here in the interest of time. The API technology supplier needs to publish all of its terms and conditions for its API technology, and we enumerate a number of specific aspects of the documentation and terms and conditions that need to be made available. And then when it comes to fees, that any and all fees charged by the API technology supplier, again, these would be permitted fees, as I get to in the next slide, for the use of its API technology must be described in detailed plain language. And it needs to include the persons or classes, the circumstances in which the fee would apply, and if there are variable fee methods. As a spoiler, we don't propose a particular single methodology for fees to be charged. So in the event that developers take different business models or practices, they would have to be at least clear about how they're choosing to create the fees and how the fees would apply, and if there are variable cost structures and methodologies, they need to make them available up front from a proposal perspective. All right, and the last one is that if API technology supplier is permitted to institute, they're permitted to institute a process to verify the authenticity of application developers. So again, this is a choice. If a health IT developer wants to add more trust to its ecosystem and warrant to its customers that they've made sure that an app developer, a third-party app developer is a legitimate business, etc., they would be permitted to do this process, but they aren't allowed to cast judgment on the actual application itself. So it's an important distinction to keep in mind. It's more about a business-to-business type of thing as opposed to the third-party app that they're vetting the authenticity of is actually producing a competing software solution. It wouldn't be that type of review. When it comes to permitted fees, there are a number of distinctions that I wanted to cover for you, and I'm probably going to take up the next 8 to 10 minutes covering this, and then breeze through really quickly toward the end on the openness and pro-competitive conditions. So when it comes to the relationship that exists vis-a-vis the statute, vis-a-vis our regulatory paradigm, the conditions of certification, and information blocking, the first layer that you need to keep in mind and how it relates to API technology suppliers that are highlighted here in the bottom left corner is that information blocking applies in different ways, but in general to all of these specific actors. And so working our way, clockwise from the bottom, we have the API technology suppliers. So in this case, it is the health IT developer of certified health IT. So they're a covered actor from an information blocking perspective. And they will have a relationship with API data providers, which are healthcare providers. So they're also a covered actor. And then the API technology supplier will have a relationship in terms of how it behaves with API users, which again could be third-party services, apps, other types of organizations with whom the API technology supplier has relationships. When it comes to the API data provider, they will have relationships with the API technology supplier from an information blocking perspective, and then similarly with API users. In most cases, the API user would not necessarily be a covered actor from an information blocking perspective, but again, the definitions that you have an opportunity to comment on would be important. So these lines connecting the various actors are really to represent the relationship and the specific covered actors that you now know that are covered by the information blocking provisions. When it comes to the API conditions of certification, that starts again with the API technology supplier, and there's a relationship between them and API data providers, and there's a relationship between API technology suppliers and API users. And the way that this plays out in more detail from a permitted fees perspective is that there are two permitted fees that can be arrived at and established between API technology suppliers and API data providers. Permitted fee number one, which relates to the development, deployment, and upgrade of API technology. And so we wanted to make sure, again, that the health IT developers are the ones that are paying engineers to make new APIs, meet the certification requirements that we have, and that they'd be able to recoup a reasonable return on their investment in order to continue to innovate and make upgrades to their API technology. And so there are guardrails and parameters associated with that permitted fee. The second permitted fee is around API usage costs, and it's important to note here that this is established between the health IT developer, the API technology supplier, and the API data provider. And so just like our consumer experiences today with our cell phone or other types of services where we establish a contract based on usage, if the API technology supplier happens to be in the situation where they're hosting on behalf the FHIR server for a healthcare organization, they would be permitted to create a permitted fee structure where they could charge API usage costs according to specific caveats and parameters. The other converse example here would be if you're a very technical savvy, large healthcare organization in the API data provider role, and you want to take on all the obligations of hosting your FHIR server and maintaining it over time, etc., then the API usage cost would not be a cost that you would be providing to an API technology supplier. And then in that case, as we identify in the rule, the API technology supplier would not be permitted to charge that type of fee to the healthcare organization. Lastly, when it comes to the relationship between API technology supplier, and let's just call them third-party services, other types of app developers and the like, we identified that there could be a permitted fee structure, a category of fees that we wanted to be able to allow API technology suppliers to charge, which we refer to as value-added services, and I have some details associated with that as well. All right, so there are two scenarios as these the triangle splits in terms of how these relationships play out. I'm going to cover the first one pretty quickly, and then move on to scenario two related to the value-added services, and then wrap everything back up. So when it comes to the permitted fees, we have a set of general conditions, which are guardrails that we've put in place, and there are four kind of general conditions. They are really, I would say, closely associated with our information blocking proposals. And so when it comes to reasonably allocating costs, reasonable and non-discriminatory practices, and anti-competitive behaviors, we've built those into the types of behaviors that, when it comes to all fees, these are the things that at a general level before a permitted fee is established that health IT developers or API technology suppliers need to keep in mind. When it comes to the specific development, deployment, and upgrade fees, so the relationship here again is between the API technology supplier and API data provider. The specific language is there in bullet 1 about the permitted fee. And then the important point here that I wanted to cover in the second bullet is that oftentimes there are, we've heard feedback from the field, and what we sought to address through these proposals is that an API technology supplier would hear from its customer it's seeking to partner with some new innovative third-party service, and the API technology supplier would say, hey, we heard you're going to partner with this cool third-party app, and if you want them to be able to connect to your API, they'll have to pay us first. And you can fill in the blank of what they would need to pay. So what we wanted to establish through our proposals and what we've sought to achieve, and you can certainly comment, is to say that decision is a decision that's made by the API data provider. And we have a specific proposal associated with our openness and pro-competitive conditions that the healthcare organization that's in the center here is the one that has the autonomy and authority to determine the third-party services with whom it wants to interact and seek other types of data services from whom. So when it comes to the API usage costs, again, the specific proposal is that first bullet. The element here contextually that I wanted to highlight is that, again, this is a relationship strictly between the API technology supplier and API data provider. And an API technology supplier is only permitted to charge the API data provider when it comes to usage costs. So if there is a third-party application that thousands, millions of a particular healthcare organization's patients choose to use, and they're using that third-party app to connect to their system, those would be charges, usage charges that would need to be resolved between the API technology supplier and API data provider. The patient access one is a particular interesting one, so hold that thought because I have another bullet on it. But to use a different example, if there was a population analytics firm that was partnered with the API data provider, and the API data provider thought that the covered services for usage were well defined within their contract, and they thought they could handle the amount of transactional volume that would occur, but then it turns out that the population analytics firm used tenfold more, that would be a usage cost contractual permitted fee that would need to, again, be resolved between the API technology supplier and API data provider. We have much more detail about how all these things are expected to work out vis-a-vis the proposals that we've included in the rule. I would also note, again, there's no particular fee amount, threshold, or methodology that we proposed, and you can read more about that in the proposed rule. All right, so there are a few things that the usage cost permitted fee excludes, and so there are some accounting principles that are excluded, but there's one that in specific that I've highlighted there with the underline. If there are costs associated with API usage that are directly to facilitate a patient's ability to access, exchange, and use their health information, those fees are not allowed to be built into the API usage cost pursuant to our proposal. Okay. When it comes to value-added services, we have, again, the first bullet here is representative of the regulatory text proposal. So we identify that the API technology supplier is permitted to charge fees to an API user for value-added services and supplied with in connection with software that can interact with the API technology, so long as the services are not necessary to efficiently and effectively develop and deploy such software in production. So we have a number of different examples. We understood that API technology suppliers, health IT developers in this case, would seek to offer market differentiating services. They want to make it more attractive for third-party services and applications to develop for their ecosystem and their customers. Examples of this in the third bullet could include advanced training. So if all the documentation is available online as we've proposed, it should be straightforward enough for a third-party app that wants to interact with the API technology to go through all that documentation. But as we all know from our various professional experiences, hearing it from an expert, going to an advanced training session is often valuable. And so if an API technology supplier wanted to offer that type of advanced training, that wouldn't be necessary to deploy an application for that ecosystem. We wanted to permit API technology suppliers to be able to charge for those types of services. In addition to premium development tools, other distribution channels, co-branding, marketing arrangements, other types of things that we felt were largely between the API technology supplier and potential ecosystem participants. Again, we put this forward to identify that this would be a permitted fee that they could charge. If you are concerned about the parameters of the particular types of pricing models or other types of behaviors that could be used in a way to prevent competition or the like, that again would be an opportunity for you to comment on this value-added services. But this is a more general permitted fee to say, generally speaking, we prohibit all fees except the ones that we permit. And so we wanted to make sure that API technology suppliers could have an ecosystem where they could interact with third-party services and offer premium services to them. Last bullet to emphasize, an API technology supplier would be permitted and continues to be allowed based on our proposals to operate their own app stores, provided, again, that they don't violate this condition of certification as well as information blocking policies. And the italicized text here underneath is an excerpt from the rule to identify a case where you know, a gatekeeping kind of approach would be in violation of the condition of certification and could raise information blocking concerns. All right, this is my last set of slides. Very briefly on the openness and pro-competitive conditions. We have a set of conditions that relate to non-discriminatory terms, but starting up front, the main proposal for this is that an API technology supplier must grant the API data provider, so the healthcare organization, the sole authority and autonomy to permit API users to interact with the API technology that's deployed by them. So again, getting back to that fee, permitted fee illustration that I provided, when it comes to the API data providers, they would be permitted to determine the businesses with whom they want to interact with for their business purposes. There are a number of specific provisions here, again, relating to anti-competitive practices and other distinguishing behaviors that could violate this condition of certification or cause concern from an information blocking perspective. That would be, you know, either deterring or preventing certain third-party services, as an example, from interacting with API technology in the context of that third-party service could be a competitor to that health IT developer that's actually supplied the API technology. The second pro-competitive condition that we've provided is around the rights to access and use the API technology. Again, this is parallels a lot of the information that we've included in an information blocking exception, and it's specifically translated with a bit more detail for the API ecosystem. The provisions to the right here about being able to interact with API technology, insofar as rights are granted for the access and use of API technology, the health IT developer, the API technology supplier, is not permitted to condition any of the rights that would be licensed, etc., on a requirement that the recipient of those rights do any of the following or agree to do any of the following. And so there are a number of provisions there that we had heard from stakeholders over time that were serving as impediments or deterrents to API technology and the use of API technology in the ecosystem. And then lastly, when it comes to service and support obligations, we have a number of proposals, or a small set here, related to the service and support obligations that API technology suppliers would need to meet in reference to the condition of certification overall. So there are a few requests for comment that I wanted to call to your attention very briefly at the end of my 60 minutes here. We have a number of options on the FHIR standard. There happen to be there have been 4 releases, 3 of which are in the market in production in various different ways. You know from my earlier part of my presentation that release 2 with the Argonaut specifications is the most prevalent in industry. However, FHIR 4 has just been released, and given timing related to our regulatory cycles and the like, we wanted to get industry feedback on whether or not we should finalize in a subsequent final rule a different approach for how we set a baseline for standards-based APIs. There are a number of other specific API-oriented requests for comment that in some cases are a bit more technical, but would very much appreciate your comments on those. And please provide them and make them as detailed as possible with any real-world scenarios that you feel comfortable sharing. And with that, right on time, I'm going to wrap up. I really appreciate your time today. I know I went through a whole lot of content in 60 minutes. very much encourage you to comment. Please visit our website, healthit.gov/NPRM. Again, the upcoming webinars on March 19th and March 28th will cover other portions of our rulemaking. And again, thank you very much for your time, and have a great day, and comment on our rule.